Welcome to episode 73. I'm Stuart McCullough, I'm the CEO of VHIA. And starting with this week's Industrial Roundup and community health in particular, there are now a number of bargaining proposals that have been issued to community health members for their consideration, including for allied health professionals, dental therapists, and medical scientists, which cover dietitians, pharmacists and psychologists. This marks a significant step forward in the bargaining process. Most significantly of all is the fact that these bargaining outcomes are based on community health and not merely a reflection of the public health sector. Drafting continues also for the Health and Allied Services Community Health Agreement. We're scheduled to meet this week again with the Department of Health and Human Services with respect to the Long Service Leave Benefits Portability Bill. This follows the development of an issues paper by the department. We look forward to continuing that discussion and the contribution of community health members to that discussion. However, for us, the two main concerns continue to be the precision as to how, in fact, this scheme would work. There seems to be some uncertainty as to how it would apply, as well as funding and the cost. With respect to health service members, we have a meeting for the mental health agreement on Monday concerning the community management workload system. There is also a SDPPWG meeting for allied health professionals. That's a rescheduling of an earlier meeting. There's also a meeting on that day of the Dental EBA reference group. On Tuesday, there is bargaining for biomedical engineers, as well as an SDPPWG for the medical scientists. On Wednesday, we'll be attending an HMO manager meeting. On Thursday, the payroll reference group meets in its expanded form for the first time. And on Friday, the SDPPWG for the HWU convenes with a particular focus on patient transport. As always, all of our activities are summarised through the VHA Community app. And that's it for this week's Industrial Roundup.
I'm not a know-it-all. Don't know why.
Welcome to the weekly update, where we go in depth with a particular subject. And joining me for this week's discussion is Senior Workplace Relations Consultant Daniel Pullin. Welcome, Daniel.
Thank you, Stuart.
Daniel, would you do the honours and reveal the clue which will indicate the subject for our discussion today?
Of course.
You may need to hold that one up for the camera, and for the benefit of those people who are listening to this podcast rather than watching, could you describe the object?
It is a novel titled Lots More, Tell Me Why.
So I'm going to stop you right there. It's not a novel.
Okay.
In fact, describing it as a novel is indeed a novel of itself. It's a big book of questions and answers. And if I was to give you an example here, let's have a look. Let's see. Oh, here's one that you might want to answer. Is the tomato a fruit or a vegetable?
It is a fruit.
You're so wrong. It is a fruit, technically speaking, but in 1893, the Supreme Court of the United States declared it for trade purposes to be a vegetable because it could be used for vegetable-like purposes. The answer to this and many other questions are available in this book, which of course leads us to the subject for today's discussion.
Has it got something to do with, the flu season, keeping up your vitamin C, eating tomatoes?
So close and yet so wrong. So we've just completed our Doctors EBA forums, and that leads us to today's subject for discussion, which is the frequently asked questions that arose from those forums for the Medical Specialists Agreement.
Wonderful.
So Daniel, we've just completed doing 6 of those forums, and I think we should start out by thanking those members, both who attended as well as those in particular who hosted.
Look, I agree. So over the previous 6 weeks, we were grateful to experience the hospitality of the Royal Melbourne Hospital, La Trobe Hospital in Traralgon, Bendigo Health, Goulburn Valley Health in Shepparton, Southwest Healthcare in Warrnambool, and Eastern Health.
I think it's worth just focusing for a moment on the number of attendees and the number of health services that attended those forums.
Across the 6 forums, we had 179 participants from each health service, and that's a respondent that was a respondent to the Doctors Agreement.
And in terms of the number of health services?
All health services that are a respondent to the Doctors Agreements attended a forum.
So well done to everyone for getting out and coming to those forums. Just a reminder, of course, though, that the last one of those forums at Eastern Health was recorded, and that video will be available within the next week or so for anyone who wants to revisit the highlights, or alternatively for those people who weren't able to get to a forum to watch. They can find it under my IR and VHIA video links.
Correct.
So we're focusing today on the medical specialists agreement. Let's start. What were the frequently asked questions with regards to that agreement?
So for medical specialists, the topics of clinical support time, fixed term employment and CME were key items of discussion.
Okay, so let's go to clause 18 of the specialists agreement with respect to clinical support time. One of the frequent questions was relevant to subclause 4. Is the clinical support duties, or are the clinical support duties that are defined at subclause 18.4 indicative or exhaustive?
So the clinical support duties definition provides a menu of duties which fall within the scope of non-direct patient care, and these are to support the operations of the unit and the health service, quality improvement activities, the maintenance of a doctor's skills and new skill development, and the contribution to teaching and education of medical staff and other health professionals.
So those 4 items that you've listed there, they're really a character of activity as opposed to actual activities themselves. They're a type of activity. So just in terms of that character, is that list exhaustive?
We would say that the character of those items is exhaustive.
All right, so whatever the clinical support time activity is, it has to be of that nature.
Correct.
In order to be a clinical support time activity. There are also a list of examples that are included within the same subclause.
That's correct. So items such as administration, attendance at departmental or health service meetings, postgraduate or undergraduate teaching, and attendance at grand rounds are included within the subclause.
So that list of examples is an indicative list as opposed to exhaustive.
Correct.
So if members are asking themselves the question, can this activity be classified as clinical support time within the meaning of the agreement, start with the character.
Yeah.
And turn your mind to whether or not it fits that character. Don't be put off if it's not one of the specific examples that's listed at 18.4.
Correct.
All right, so I understand there was also a particular interest in the application of the 50% clinical support time for unit heads, especially for those doctors who may work as a unit head on a fractional basis or have a fractional unit head appointment in their clinical area of expertise.
So that's correct. So a common question from attendees was, does a fractional unit head receive 50% minimum clinical support time allocation on their unit head contracted hours only?
So we would agree with that as a general proposition, wouldn't we?
We would. It's possible that a doctor can be engaged as a unit head for a fraction, and that fraction should attract the 50% clinical support time. The doctor will be entitled to devote 20% of their normal weekly hours assigned to the non-unit head fraction for clinical support duties.
Are there any other key messages with regards to the clinical support time provision that are worth emphasising?
So we'd say the key message we want to express to our members is that the clause still prescribes that the actual quantum of clinical support time allocated to a doctor is agreed between the doctor and the health service.
That component has not changed.
That's correct.
So moving to a different clause, one of the other items that came up quite frequently concerned the changes to the fixed term contracts clause. So for those members who have their agreement with them, we're talking about clause 16.4. So the question that came up is whether a health service can appoint doctors to fixed term unit head or other senior appointments.
So we'd advise that the fixed term employment subclause at 16.4 applies only to the doctor's substantive contract of employment. The clause doesn't seek to limit the appointment of a unit head or other roles for a fixed period where the appointment is not their substantive contract of employment.
So there's really a distinction there between the mode of employment, which in that example is permanent, there is ongoing employment underpinning it, and a time-limited appointment to a responsibility such as unit head.
That's correct.
Those are two very different things that can be distinguished.
Agreed.
So the clause provides that fixed-term employment will only be used to meet genuine fixed-term needs, with a list of genuine fixed-term needs identified within the clause. One of the frequent questions was, Is that list contained in that subclause indicative or exhaustive?
So the clause itself suggests that the list is indicative. Subclause 16.4D provides genuine fixed-term needs include, but are not limited to. We would suggest that the key consideration here is that health services are engaging a doctor on a fixed-term basis for a genuine reason.
I think it's worth emphasising that flexibility shouldn't be used as an opportunity to maintain existing practices without thinking about whether or not there is a genuine need for the fixed-term arrangement.
Correct.
And just in terms of that, it would be fair to say that the health service then shouldn't be afraid to consider a fixed-term contract if it is for a genuine purpose and not be put off by the fact that the example, that their particular circumstance is not one of the examples.
I agree. So where the reason for the fixed-term contract isn't prescribed within the clause, there needs to be active consideration of the reasons. The fact that it's not within the list doesn't mean that you can't do it, but you need to genuinely consider the reasons for the fixed-term employment.
So just in terms of that, we're really saying that the objective here is to not do these things on autopilot, to give actual consideration as to the need. And if health services form a view that it is appropriate to have a fixed term contract for the circumstance, and it's not one of the examples, so be it. But it's about it not being automatic, that people are utilising fixed term contracts for this cohort.
Correct.
So one of the other areas for discussion during the forums concerns CME, and perhaps that's no surprise. So we're talking about Clause 41 of the proposed new agreement. What were the key themes with respect to CME during the forums?
So overall, members welcomed the extended period within which they can process a compliant CME claim. That's been moved from 30 days to 45 days, but had reservations with respect to the ability for a doctor taking CME to claim a fixed $250 per day to facilitate the costs of childcare whilst undertaking a CME activity.
Okay, and obviously it's no surprise that there are questions about how that is going to work, and I think one of the points that we made during the forums is that we're going to learn about how it works, but it has a good purpose with respect to it. But it is a new entitlement, and we'll figure out what works well and what doesn't work well as we go through the agreement life.
That's correct. So throughout bargaining, it was clear that work was necessary to provide gender equity. One item was the challenges experienced by female doctors who are predominantly the primary carer of children in accessing CME.
So one of the things about that provision, though, is that the clause is quite direct and explicit about the need to provide evidence.
Correct.
What kind of evidence, and evidence of what?
So a doctor seeking to claim the fixed $250 per day to facilitate the cost of childcare whilst undertaking a CME activity must establish throughout the production of evidence that satisfies a reasonable person that they were the primary carer and are responsible for the child or children during the CME period.
So that phrase, evidence that would satisfy a reasonable person, that's a phrase that's used under the Fair Work Act, and it does mean that something like a statutory declaration could satisfy the evidentiary requirements. It may not be necessary for there to be a stat dec to satisfy the evidentiary requirements, but it is a test that is part of the general industrial relations framework.
That's correct.
So we were asked during the course of our forums about that $250 per day for the childcare, and in particular whether or not that quantum was to be deducted from the CME cap or not.
So it can. So childcare expenses in accordance with subclause 41.3D are deducted from the doctor's annual CME cap.
It was really interesting to get feedback from members with regards to that provision, and one of the concerns raised was, well, given that this is a cost that may only be incurred or more likely to be incurred by a particular gender, whether that is equitable or not. But again, we're going to learn through the application of this clause what works well and what doesn't. So I understand that there was also a request for further clarification about the special carryover provisions. Again, a new provision. Primary work that it has to do is around parental leave, but those provisions there at clause 41.5.
So that's correct. So members indicated they would appreciate additional guidance in implementing this subclause in particular. we'll be devoting a podcast and additional implementation material to the special carryover entitlement in the coming weeks.
So for those members who are keen to keep track of implementation issues, what's the best way to do that?
So members would note that every month we send out with the ER and IR Director's agenda a implementation tracker. So last month was the first month where we had identified a list of implementation issues. We've been updating that following each Doctors EBA forum. We also provide a copy of that on the VHIA community app. So if members were seeking to get an update on our most recent SDPP WG meeting from last week, they'll be able to see an update on the matters we discussed and the next steps forward on the VHIA community app.
Okay, so for those people who aren't familiar with that monthly written report, as well as the implementation tracker, they are sent to HRIA managers ahead of the monthly meeting, but most importantly, they are posted through the general feed on the community app. If members haven't yet activated their community app account, we'd encourage them to do so. It's the best way to see where we're up to in terms of progressing those additional implementation items. Probably worth flagging that we'll be doing another one of these podcasts for the Doctors in Training Agreement very, very shortly.
Correct.
Daniel, thank you so much for covering off those frequently asked questions that arose through the Medical Specialists Agreement. I think we should continue. The learning that we've experienced this afternoon, and perhaps turn to lots more Tell Me Why. And the question I have here is, what is St Elmo's Fire?
Does it have something to do with Sesame Street?
Daniel, you're so wrong. St Elmo's Fire is one of the many interesting phenomena connected with lightning, and to understand it we must review what takes place when lightning occurs. You know, I've read so much of that description so far, and I'm yet to get to the bit where Rob Lowe plays the saxophone. Daniel, thank you so much for your time today.
Thank you, Stuart.
I can see a new horizon underneath